Question 1. A 30-year-old man with a background of type 1 diabetes and asthma presents with 3 days history of worsening cough, chest tightness and wheezing. His inhaler use has increased and he has been unable to sleep at night. Despite being ill, he has maintained a good insulin regimen. He presents to the ED with difficulty in breathing. He is struggling to talk. On examination he appears to be in distress. His respiratory rate is 32, SpO2, 85% in room air. Bilateral widespread wheeze is heard on auscultation. He received oxygen-driven salbutamol nebulizer back-to-back along with 0.5 ml ipratropium bromide added to it and 100 mg IV hydrocortisone. He did not show much improvement. Intravenous magnesium sulfate is administered. He was discussed and referred to the medical registrar who assessed and has started him on intravenous salbutamol. Following are his blood results: sodium 135, potassium 3, urea 6, creatinine 90, random blood sugar 15, which is the single most likely cause for the above results: A. Hydrocortisone, B. Magnesium sulfate, C. Salbutamol, D. Ipratropium bromide. Salbutamol can cause tachycardia, hyperglycemia and potentially serious hypokalemia. Patients can experience tremors and twitching with salbutamol overuse. In diabetic patients, it is important to monitor glucose levels if receiving treatment for severe or life-threatening exacerbations. Answer: C. Salbutamol concept tested. Side effects of asthma medications. Question 2. A 25-year-old presents to the GP due to difficulty sleeping at night for 2 months. He has chest tightness accompanied by coughing. He is known to have eczema since childhood. His brother is a known asthmatic. He was referred by his GP for a spirometry which was normal. What is the single most appropriate test to help a diagnosis? A. Chest X-ray, B. Peak flow diary, C. Full blood count, D. Arterial blood gas. If there is diagnostic uncertainty after initial assessment, a peak flow diary can help. A variable peak expiratory flow greater than 20% is considered positive. It should be monitored twice daily for 2 to 4 weeks. Answer: B. Concept tested. Asthma diagnostic tests. Question 3. A 40-year-old obese man, known asthmatic, is visiting his GP due to increase in his asthma symptoms. He has recently been experiencing headaches. His brother, who has a history of migraines, suggested that he should take an over-the-counter medication for his pain. He took the same medication his brother uses for migraine. What is the single most likely medication that would have caused an increase in his symptoms? A. Ibuprofen, B. Paracetamol, C. Loperamide, D. Cimetidine, E. Omeprazole. Symptoms of asthma can present after taking aspirin, NSAIDs and beta blockers. Answer: A. Concept tested. Asthma exacerbation. Question 4. A 25-year-old lady recently diagnosed with asthma is on salbutamol and inhaled corticosteroid inhalers. She recently joined the gym but having cough and breathlessness once she starts her exercises. It is causing her much difficulty. Which of the following is the next best step in management? A. Add on montelukast, B. Add on sodium cromoglicate, C. Increase inhaled steroid dose, D. Oral prednisolone for 5 days, E. Add on shitropium. If exercise is a specific problem in patients taking inhaled corticosteroids, consider adding one of the following: leukotriene receptor antagonist, long-acting beta-2 agonist, sodium cromoglicate, or nedocromyl sodium theophylline. If leukotriene receptor antagonist is one of the options in the questions, then choose LTRA rather than sodium cromoglicate. Montelukast is sometimes prescribed as daily dose or to be taken before exercise only. It should be given 2 hours before exercise and has an effect up to 12 hours. Answer: A. Concept tested. Exercise-induced asthma. Question 5. A 30-year-old known asthmatic who is currently on salbutamol inhaler and low-dose beclomethasone visits the GP due to his asthma symptoms. He is requiring the salbutamol inhaler more than 3 times a week and wakes up at night on some days due to coughing and chest tightness. He finds it hard to concentrate at work the next day due to lack of sleep the previous night. According to the British Thoracic Society, what is the single most appropriate medication to be prescribed? A. Montelukast B. Increased dose of beclomethasone. C. Sarmatrol inhaler. D. Oral prednisolone. The next step in asthma management is to add a long-acting beta-2 agonists or leukotriene receptor antagonists. An easy way to remember this is as follows. BTS has a B, so add long-acting beta-2 agonists. Answer: C. Concept tested, asthma stepped-up management. Question 6. A 25-year-old, known asthmatic presents to the emergency department with difficulty breathing and wheezing. On examination she appears distressed. She sits hunched forward, finding it difficult to complete her sentence. Her respiratory rate is 30 breaths per minute and heart rate is 115 beats per minute with an oxygen saturation of 92%. On auscultation bilateral wheeze is present. Oxygen is commenced. What is the single most appropriate initial management? A. Nebulized salbutamol. B. Intravenous salbutamol. C. Intravenous hydrocortisone. D. Intravenous antibiotics. Patient is having a severe exacerbation of asthma. Patient should receive nebulized salbutamol plus ipratropium bromide added to the nebulizer. Administer 100 mg IV hydrocortisone. Answer: A. Concept tested, asthma exacerbation management. Question 7. A 35-year-old man, known asthmatic, presents with a severe exacerbation of his asthma. He has received oxygen-driven salbutamol nebulizer along with 0.5 ml ipratropium bromide added to the nebulizers. In addition to this, he has received 100 mg IV hydrocortisone. On assessment he shows no improvement. What is the next step in management? A. Intravenous salbutamol. B. Intravenous aminophylline. C. Intravenous magnesium sulfate. D. Intramuscular methylprednisolone. Steps to treatment are as follows. 1. Oxygen. 2. Salbutamol nebulizer. 3. Ipratropium bromide nebulizer. 4. IV hydrocortisone or oral prednisolone. 5. IV magnesium sulfate. 6. Aminophylline or IV salbutamol. To be discussed with senior. Anyone with life-threatening features who do not show improvement must have an ICU or HDU bed arranged. Answer: C. Concept tested, asthma exacerbation management. Question 8. A 60-year-old with poorly controlled asthma on multiple medications has visited her GP for ongoing symptoms. The GP has decided to start her on long-term oral steroids. The patient, who is worried about being started on oral steroids, asks the GP if she may experience any side effects. Which of the following side effects must have been discussed with her? A. Oral candidiasis. B. Osteoporosis. C. Osteomyelitis. D. Osteochondritis. E. Low blood sugar. Short-term use of steroids can cause insomnia, irritability, indigestion. Long-term use of oral steroids can cause osteoporosis, GI bleed, weight gain, muscle loss, cataract, diabetes. Oral candidiasis is a side effect of inhaled corticosteroids. Answer: B. Concept tested, side effects of asthma medication. Question 9. A 25-year-old, heavy smoker presented to the GP with a history of cough since 3 months. She has no family history of asthma or allergies. She has had a chest X-ray which is normal. A spirometry done shows the FEV1 by FVC ratio less than 0.7. Which of the following investigations will help differentiate between asthma and COPD? A. Peak expiratory flow rate. B. Repeat FEV1 by FVC. C. Post-bronchodilator FEV1. D. FEV1. There is no single diagnostic test to confirm asthma. Use clinical judgment and objective tests. An FEV1 by FVC of less than 0.7 is indicative of obstructive lung disease. Both asthma and COPD are causes of obstructive lung disease. Asthma is reversible while COPD is a progressive disease. To differentiate between the two, it would be helpful to do a bronchodilator reversibility testing. An improvement in FEV1 greater than 12% and increase in volume of greater than 200 ml is considered positive. FEV1 is the volume exhaled in the first-second peak expiratory flow is not used in the diagnosis of COPD because the main disorder is in the peripheral airway and PEFR measures functioning of the larger airways. Answer: C. Concept tested, diagnosis of asthma. Question 10. A 35-year-old man presents with a moderate exacerbation of his asthma. The GP decides to give him a short 5-day course of oral steroids. What is the most common side effect of oral steroids the patient may experience? A. Weight gain. B. Osteoporosis. C. Muscle loss. D. Insomnia. E. Cataract. Since the patient is receiving only a short course of steroids, the most likely side effect the patient may experience is insomnia. Short-term use of oral steroids cause insomnia, irritability, indigestion. Long-term use of oral steroids cause osteoporosis, GI bleed, weight gain, muscle loss, cataract, diabetes. Oral candidiasis is a side effect of inhaled corticosteroids. Answer: D. Insomnia. Concept tested, side effects of asthma medication. Question 11. A 35-year-old known asthmatic presents to the ED struggling to breathe. He can barely complete a sentence. He has been given back-to-back salbutamol with ipratropium bromide 0.5 ml added to the nebulizers. He has also received IV hydrocortisone. He shows little improvement. He is administered IV magnesium sulfate and reassessed. On examination, his lips and fingertips appear blue. An arterial blood gas done shows the following: pH 7.3, PCO2 6.5, PO2 11, base excess -4. What is the next most appropriate management? A. Repeat ABG after 30 minutes. B. Admit to intensive care unit. C. Admit to ward. E. Give normal saline nebulization. Identifying life-threatening or near-fatal asthma is important. Appearance of cyanosis suggests that there is a shortage of oxygen in the blood. Respiratory acidosis indicates that the patient is tiring out and unable to get rid of carbon dioxide, which results in a build-up in the body. The patient is at risk of an imminent respiratory arrest. It is important to inform the anesthetist, and ICU treatment options include intubation and ventilation or ECMO. Answer: B. Admit to intensive care unit. Concept tested, asthma exacerbation management. Question 12. A 33-year-old lady presents with cough since 4 months. She has tried multiple home remedies including cough linctus and normal saline nebulizations. She has seen very little improvement in her symptoms. She has no family history of asthma or allergies. A spirometry conducted was normal. Last 2 weeks have been particularly difficult for her. She has difficulty sleeping at night due to the cough and chest tightness. She is unable to perform at her workplace and taking days off. What is the next best step in making a diagnosis? A. Repeat spirometry. B. Trial of inhaled corticosteroids. No objective tests required. C. Trial of inhaled corticosteroids and arrange for a fractional exhaled nitric oxide test. Patient is currently having a poor quality of life due to asthma symptoms. Before any objective tests are done, patient needs treatment for her symptoms. Sometimes a treat-to-diagnose method can be used to help diagnose asthma. If starting patient on reliever and preventer medications help control symptoms, then asthma is the most likely diagnosis. NICE guidelines suggests that clinical judgment along with objective tests must be used in order to diagnose asthma and moves away from diagnosing asthma on clinical symptoms alone. Answer: see trial of inhaled corticosteroids and arrange for a fractional exhaled nitric oxide test. Concept tested, asthma diagnosis. Question 13. A 38-year-old known asthmatic visits the GP due to her asthma worsening in the last couple of weeks. She is on salbutamol and low-dose beclomethasone inhaler. She has been using her salbutamol inhaler 6 times in a week. She awakes at night at least twice in a week due to her continuous cough. The asthma is particularly worse in the morning. She maintains a peak flow diary and her readings are 250 ml in the morning. On examination she appears to be coughing as she talks. She speaks in full sentences. Her RR is 20, pulse 88 and SpO2 96%. She has bilateral wheeze on auscultation. What is the next best step in treatment according to the NICE guidelines? A. Add montelukast. B. Add salmeterol. C. Increase dose of beclomethasone. D. Start oral prednisolone. The next step in asthma management is to add a long-acting beta-2 agonist or LTRA. An easy way to remember this is as follows. BTS has a B, so add long-acting beta-2 agonist, else add leukotriene receptor antagonists. According to NICE guidelines, the best next step in treatment would be to give montelukast. Answer: A. Add montelukast. Concept tested, asthma stepped-up management. Question 14. Which of the following signs indicate life-threatening asthma? A. Tachycardia. B. Tachypnea. C. SpO2 96%. D. Peak expiratory flow rate 50%. E. Absent breath sounds. Life-threatening features of asthma includes patient appearing exhausted, confused or in coma, PEF less than 33%, best or predicted SpO2 less than 92%. Patient may have bradycardia or dysrhythmia and could be hypertensive with a feeble respiratory effort or cyanosis. Auscultation, silent chest, absent breath sounds, an arterial blood gas showing normal PaCO2 needs to be taken seriously as it indicates that patient is tiring out and unable to expel carbon dioxide. Senior clinicians and A2 need to be informed to prevent a respiratory arrest. Answer: E. Absent breath sounds. Concept tested, asthma exacerbation diagnosis. Question 15. A 30-year-old male smoker with a history of eczema and a family history of asthma in his sibling presents with fever and shortness of breath. He was discharged and arranged for a spirometry 6 weeks later, which was 2 by 3.5. A post-bronchodilator FEV1 by FVC was 3 by 3.5. What is the most likely diagnosis? A. Pulmonary fibrosis. B. Asthma. C. COPD. D. Pulmonary edema. An FEV1 by FVC ratio of less than 0.7, in this case 0.57, is indicative of obstructive lung disease. Both asthma and COPD are causes of obstructive lung disease. Asthma is reversible while COPD is a progressive disease. To differentiate between the two, it would be helpful to do a bronchodilator reversibility testing. An improvement in FEV1 greater than 12% and an increase in volume of 200 ml is considered positive. In this case, FEV1 has increased by 28%, so from the options provided the diagnosis is asthma. Answer: B. Asthma. Concept tested, asthma diagnosis. Question 16. A 32-year-old recently diagnosed asthmatic presents to the ED with a moderate exacerbation. Her regular medication includes salbutamol inhaler used when necessary. She is treated with 10 puffs of metered-dose inhaler. Her symptoms have settled. You check her inhaler technique and give her standard advice. What is the most appropriate further action? A. Discharge after checking her peak expiratory flow. B. Discharge and give 50 mg of oral prednisolone. Stat dose now, for 5 days. C. Give 50 mg oral prednisolone. Stat dose now, for 5 days and beclometasone inhaler 200 microgram twice daily. D. Discharge and ask to be followed up by GP in 24 hours. The patient has presented with an acute exacerbation and treatment would include salbutamol 4 puffs initially, then 2 puffs every 2 minutes, up to 10 puffs, plus oral or intravenous steroid. 40 to 50 mg oral prednisolone should be given for 5 days in total. Patient's asthma is clearly not well controlled, so she can be given a low-dose inhaled corticosteroid on discharge. It would be important to check her peak expiratory flow every 20 to 30 minutes after receiving treatment. A peak expiratory flow greater than 75% best or predicted would mean that the patient is fit for discharge. A GP follow-up arranged within 2 working days and inhaler technique checked on discharge. Answer: C. Give 50 mg oral prednisolone. Stat dose now for 5 days plus beclometasone inhaler 200 microgram twice daily. Concept tested, asthma exacerbation management. Question 17. A 24-year-old lady known asthmatic recently gave birth to a baby. Her asthma is well controlled for the last year and she has been only on salbutamol inhaler PRN. She presents to the hospital with a moderate exacerbation of asthma. She improved after salbutamol nebulization. She is prescribed 40 mg oral prednisolone for 5 days with a stat dose prescribed for now. She is concerned about breastfeeding her baby while being on steroids. You are the Foundation House officer. What will you do? A. Half the dose of oral prednisolone. B. Advise mum to stop breastfeeding. C. Switch to montelukast. D. It is safe to continue prednisolone and breastfeed. Only small amount of steroid enters the breast milk. This will not cause any adverse effect on the baby. It is safe to take oral prednisolone and inhaled corticosteroids. Answer: D. Advise mum that it is safe to continue prednisolone and breastfeed. Concept tested, asthma medication. Question 18. A 34-year-old man presents with persistent cough. He is otherwise well. The GP wants to take further history to help make a diagnosis. Which one of the following makes the diagnosis of asthma more likely? A. Only gets symptoms after having an upper respiratory tract infection. B. Peripheral pins and needle sensation. C. Symptoms worsen after exposure to cold air. D. Small amounts of productive cough with clear sputum. While viral infections can trigger an asthma attack, those with asthma would experience asthma symptoms without a viral infection too. Symptoms of asthma include cough, shortness of breath, wheezing, chest tightness, and can occur in response to exercise or allergen exposure or cold air. Occupation-related, exacerbated by viral infections and medications like NSAID, beta blockers. Answer: C. Symptoms worsen after exposure to cold air. Concept tested, asthma diagnosis. Question 19. A 25-year-old, known asthmatic on salbutamol and beclometasone 400 micrograms twice daily developed sudden onset left-sided chest pain during a game of tennis. On examination he appears short of breath. His oxygen saturation is 95% en room air. On auscultation there are reduced breath sounds on the left side. What is the single most appropriate initial investigation of choice? A. Arterial blood gas. B. Chest X-ray. C. CT chest. D. Troponin in the MRI chest. Asthma is a predisposing factor for spontaneous pneumothorax. Chest X-ray is the most appropriate investigation for diagnosis. Answer: B. Chest X-ray concept tested, asthma diagnosis. Question 20. A 55-year-old is on medications for ischemic heart disease, hypertension and hyperlipidemia. At night he complains of shortness of breath, chest tightness and wheezing. Which of the following is responsible for this? A. Simvastatin, B. Bendraflumethiazide, C. Ramipril, atenolol, E. Amlodipine. Asthma can be precipitated by beta blockers. Even cardioselective blockers can precipitate or aggravate asthma. Answer: D. Atenolol concept tested, asthma diagnosis.